Hello, everyone. This is Dr. Ahmed Ashraf. I am a periodontist from Egypt, and I'm really glad and honored to be with you today in the Osstem Europe On Demand section. I'll be discussing an interesting topic that intrigues many young clinicians and implantologists, guided implantology in the aesthetic zone, concerning the use and making the best benefit out of the OneGuide Kit. I've been using it for 2 years so far, and I've been pretty satisfied with the experience. I've been using the whole system for 6-7 years, and for the past 2-3 years I've been a key opinion leader for Osstem in the Middle East and Africa. This is the second time for me in the Europe section, and let's start our presentation. That was a short introduction. My affiliation: I'm a periodontal plastic surgery specialist and an implantologist. Particularly, I consider myself more interested with reconstruction of soft tissue and bone around implants in the aesthetic zone and in full arch reconstructions. I've been teaching students for 10 to 12 years so far, and my presentation today is going to be divided into 4 sections. The first thing, sequentially talking about teeth and implants. Each and every one has a different way of perception that we have to see in a different way, and consequently we're going to treat also in a different way. The second thing is computer guided implantology and computer guided implant placement. What's the difference between only doing a guide to place an implant in a good prosthetically driven position and doing a guide to serve a whole treatment plan that suits the patient and yields an aesthetic result with also the final crown? The third section is the difference between good implant and good implant system. What are the components of a good system to be able to use it in many opportunities in service of our patients? And the last thing is the OneGuide Kit, the most interesting part of the presentation that I loved most during the preparation. Let's start with teeth and implants. Actually, we all know the differences histologically between the supercrestal fibers around teeth and around implants. The tooth is a living structure having multi-layered structure from dentin to cementum, with the sharp base fibers and a periodontal ligament attached to the root, and the supercrestal fibers all attached to the root immediately. Yet we don't have these around implants. So we can't see teeth like these in the x-rays, living for 10 years, 15 years, and 20 years without much support of thickness of bone and tissue. Yet the tooth is perfectly in place, but we can't say that we can rely on these parameters for implant success. So the last consensus by the classification of 2017 just agreed upon that we have to have 2 mm of thickness and 2 mm of keratinized tissue width around implants, especially in the aesthetic zone, to yield an aesthetic result, a good emergence profile, a cleansable prosthesis that the patient can use without complaining many years to go. Also, the height of the tissue is a very critical part that is overdue. The better height you have in the aesthetic zone, especially when you have immediate implant placements, maybe 4 or 5 mm apical to the future gingival zenith, would be okay to give you room to create the soft tissue that you need and make your implant crown looks more natural. This is how it looks between the same case, 2 different tissue conditions, same crowns and same implants. Nothing has changed, only the tissue has been grafted from the left picture to the right picture to have this thickness and this keratinization. Also another case with very thin tissue, non-keratinized, non-attached, causing long-term peri-implant mucositis that needs to be grafted to be managed to have a better implant soft tissue and less bone loss and better experience for our patients. So in the past years, osseointegration and 2 mm of bone was the main success parameters that we thought about. Yet in the past maybe 10 years, we shifted this way of thinking towards having better tissue, better keratinized tissue, better thickness, and a supercrestal complex, the name that just emerged in literature due to all these parameters that we started thinking in a different way other than the old days of only having thickness of bone around the implants. Yet now we need more tissue. Our understanding now is better, and we know better than the value of the keratinized tissue and the value of the thickness of the tissue is recorded in literature. Even we can achieve this with grafts, we can achieve it with artificial materials, but we have to think about this point. Also, 70% of our cases will have a problem of color match with implant placements. We deal with extracted sockets, we deal with residual ridges remaining for 3-4 years without tooth replacement. We deal with atrophied tissues. The bone and the tissue lose volume after tooth extraction. So while placing the implant, you have to make sure that we have adequate thickness to cover up the color of the abutment, the color of the implant, the grayish color, and also thickness of the bone and tissue to support the future crown. So a minimal of 2 millimeter, as we said before. More than this, 4 or 5 millimeter would be optimum from the surface of the implant to the surface of the tissue, looking from an occlusal view. The more you have, the better for the future result and the better for the emergence profile. The biologic width, one of the terms that differ completely in understanding between teeth and implants. We only have 1.5 to 2 millimeter on a tooth to consider this is biologic width, and it's in a vertical direction. Although implants don't work this way, we have to have a very profound distance of thick tissue in both horizontal and vertical directions, maybe a 1.4 to 2 millimeters beyond the finish line of the prosthesis is needed to ensure thickness of the tissue that won't have any problems with time. And this horizontal component of the biologic width was a concept introduced by Dennis Turnow back then, after the definition of the biologic widths around teeth. So this is what we need. This is what we need to see: a bulky tissue, keratinized, fixed, non-movable, and a good emergence profile. And the theory behind this, that the core of the connective tissue and the periosteum are the ones that carry the protection of the tissue around teeth and also around implants. The core connective tissue always is responsible for this phenomenon. So the phenotype, the biotype, previously named the biotype, now is the phenotype, is responsible for having this good profile. Without a graft, we will not be able in maybe 80 to 90% of cases of implants in the aesthetic zone to achieve a good result. Graftless implantology is an option. It's always an option, but it's definitely not the optimum option that we need. It will not always go without grafting. Sometimes we have to add more tissue to increase the thickness. We have to add more tissue to increase the nature of tissue around teeth. So grafting has been a part of the game that we all have to accept and understand and be trained to do to our patients in our everyday practice. Back to the 4 sections of our presentation. The second section will be the difference between computer-guided implant placement and computer-guided implantology. And by we mean by this section is, in the previous days, we used to make the digital smile design in a 2-dimensional, and then it evolved into a 3-dimensional planning through the STL files and the DICOM files that we take from the CBCT from the patient. Then we started formulating a sequence for having a digital design for the final prosthesis of the implant prior to placement of the implant position. So virtual wax up is done, then the surgical guide is done accordingly to support the position of the tooth that has been determined by the wax up, and therefore when we place the implant through the guide in this position, it's going to aid in the final result in getting the tooth position in the desirable area that we want it to be in the cingulum of the anterior tooth. Getting the good profile with the EBC zones with the healthy curvatures of the crown that yields a long-term result with this patient. That was a brief of how we plan surgical guides according to their prosthetically driven position. Therefore, It's not just only the implant position, but also the soft tissue position and the crown position and the bone crest position. All these determinations that we think about during the implant placement is not only about the position of the implant, but also about the position of the soft tissue and the future crown that will come afterwards. So we think macro and we start acting micro. We think about the bigger picture, about the final tooth from the face of the patient with the incisal display. Then we start working backwards through our segmented models and intraoral scans to get the concept of guided implantology, not just guided implant placement. It's not just I want to put the implant in a good position, but I want everything to be in harmony from the implant position to the soft tissue thickness to the bone thickness to the final restoration with its curvature. And actually, predictability is the greatest benefit that we have from virtual surgery, that we know by 99% what we will end up with prior to even starting doing the surgery. And actually, this is the strongest tool that we rely upon in guided surgery. Why do we do guided surgery? Because it's predictable, because it yields similar results like the plan. It's not because it's easier or we cannot actually do the conventional surgery. Sometimes the conventional surgery is more easier and time saving, but guided surgery is definitely more predictable through softwares, virtual planning, and all the steps that I just explained going through. Softwares nowadays are just really equipped to do many things, as comparison of many STL models, superimposing STL models, superimposing x-rays, and measuring differences between old scans and new scans, old CTs and new CTs. For example, before the implant placement and after the implant and the soft tissue grafting, we can take a cross section and see the blue line is the new and the red line is the old part of the soft tissue. We can take a CT and measure on the CBCT before and after, and we can measure how much bone we gained in a vertical or horizontal amount. We can compare our wax up to the position of the soft tissue before the grafting and after the grafting, and determine how much tissue do we need. So it's not only about the implant position, it's always about the bigger picture, having bone, tissue, restoration, and implant position in harmony together. 2 surgeries, and we superimpose the result of the second surgery over the first surgery, and we start comparing how much bone did we lose, how much bone did we gain, and the final picture is that we have the implant embedded in bone that is going to support in the future a good looking crown. Also, one last application that actually intrigued me and I saw quite interesting is in the analysis of the surface topography of the bone. Sometimes we need to do bone augmentation in confined defects and in non-confined defects. So we need defect analysis. We need to see, is this defect a confined one? Is it a deep one, an easy one to reconstruct by collagen membranes, for example, or it's a flat defect that we need more rigid membrane, or we need more overfilling by a harder material to get the result that we need. And after this analysis, we start determining the material of choice that we're going to use, bone or membrane. Then we start implementing this plan accordingly to serve the purpose. So basically, these are the 4 aspects that we should think about during guided implantology: restorative design, implant position, supracrestal complex planning, and this is the one that I'm going to explain thoroughly right now, and the ridge defect analysis. What about the planning of the supracrestal complex? The supracrestal fibers around the implant are very critical to support a good looking crown. See how the crown improves in tissue color, in topography, and in volume after we just pay more attention to the supracrestal part of the fibers. In the old days, we only used to think about osseointegration of the implant into the bone. How much bone is attached on the implant? then we started thinking in a different way. With the years, we started seeing crestal bone loss. Then crestal bone loss took the attention as a phenomena. Why does it happen? Eventually, a stable supracrustal complex will have less bone loss with the years. And a prosthetically driven implant, we will yield together with a stable supracrustal complex a biologically driven implant therapy. And this is a new term actually that I heard from one of my mentors, and drove me to think about the supracrustal complex in a much more detailed approach, looking beyond that this implant is osseointegrated or not and is prosthetically driven or not. You have to think about many angles in the restorative crown, and many angles in the tissue, many angles in the bone, and the platform switching, the implant shoulder position, many factors that we should consider during the planning of guided surgery in the aesthetic zone to minimize this crestal bone loss and support the stability of the supracrustal fibers. I summarized those planning points into these 3 points: the emergence angle of the crown, implant shoulder position, and buccal angle concavity in cases of bone defects that we need to reconstruct by a bone in the membrane. So the emergence angle is the angle from the platform of the implant to the maximum crestal contour of the restoration. For example, these 3 crowns have we can have similar implant sizes but different implant depth between the first, the second, and the third one. With the one on the right, the most superficial implant, we have a 90-degree angle between the crown and the implant. With the one on the left, we have a more gradual angle coming down from the emergence profile from the implant platform to the crestal contour of the crown to the contact area. And eventually, tissue behaves differently in those 2 situations. In the right one, you will have the tissue having not so much healthy profile due to food accumulation below this crown and in direct contact with the crestal bone. Maybe it's going to cause more bone loss due to bigger emergence angle. And the one on the left, on the other hand, with the gradual angle between the profile and the contact area, will have a more cleansable profile, and the plaque accumulation in the zone around the neck of the implant won't face the crestal bone, rather than the sides of the interdental bone between the implant and the neighboring tooth. So it was agreed upon in literature that an emergence angle, mucosal emergence angle of the crown between 30 and 40 is going to be considered hygienic and healthy and maintainable. So while placing an implant position and designing the crown over the implant, it's preferable to maintain this angle below the 40-degree angle, 30, 33, 35. All this is good, not only in a screw retain position, but also in a screw retain position with a cleansable contour of the crown. We have 2 designs. The one on the left is cement retained, the one on the right is screw retained, and the difference is the cement retained here having a minimal angle and a more hygienic crown, and the screw retained has a maximum angle and less hygienic crown. It's not also always screw retained is better than cement retained in regard to these matters. As much as we can, we try to minimize the crown angle to yield a better soft tissue profile with less soft tissue complications like recession and inflammation and so on. The second thing is the implant shoulder position, and it has been a regimen nowadays in past maybe 10 to 15 years to go palatal with our implants as much as possible. And that is why, especially with immediate implants in the aesthetic zone, that the buccal concavity can affect the resorption pattern of the bone after implant placement. So as much as possible, keep the implant position in a bodily palatal position to minimize this effect of the angle, the position of the buccal, the position of the platform of the implant. Whenever palatal is better, it's gonna save you some bone loss on the buccal contour and cause less complication with time. The third thing in this section, planning the supracrustal complex, is the alveolar bone morphology. When we have a bone defect, like this one for example, and we now are hesitant, what type of bone graft should be placed here? 50% allograft and 50% xenograft, or 100% xenograft, or a rigid membrane or soft membrane. Actually, a very nice publication came out maybe 2 years ago or 1 year ago that quantifies the angle of the buccal defect prior to the surgery by measuring the buccal concavity angle. Is it less than 151 or it's greater than 151? When we have flat angles like this one in this video, then we will have a flat angle that needs a rigid membrane. We need a hard membrane, maybe a bone plate, maybe a PTFE membrane, maybe a titanium mesh to just reconstruct this defect. And if we use a collagen membrane, we need to overfill this defect with xenograft, because eventually it's gonna contract in half. We're gonna lose half of this volume. So better put more than we need, double the amount, because after it contracts, we have a very good volume afterwards. So this is how it looks like in a cross section. The yellow is after the surgery and the purple is before the surgery. An occlusal view, and this is how it looks after tissue conditioning and temporization. Very beautiful contour, maintaining this volume, because before we started, we just evaluated our angles and checked if we have a flat angle or a concave confined angle. So with rigid membranes, we apply rigid membranes with more flat angles, and we apply soft membranes with more confined angles. This is a case of similar situation, but the angle actually is different. It's a full arch reconstruction. We place the implants, and we need to do a reconstruction for this buccal bone concavity to restore the labial convexity to around the implant crowns later on. So this is the typical analysis of the DICOM file segmented to an STL model and measurement of this concavity angle less than 151, so 141. So we only need a soft membrane to restore this. We place our implants and try in our provisional restoration. Place soft membrane. This is a collagen membrane and a mixture of allograft and xenograft. Then pull everything up to support the tissue. Actually, this surgery was so recent, I didn't have follow-up afterwards. So those are the three optimization points that I think about during the guided implant placement, guided implantology section, to provide a good plan that supports a good crown for the patient and that is cleansable with stable supracrustal complex and a nice looking soft tissue and lasts long. Back to our common slide, the 4 sections of the presentation. We finished it number 1, number 2, and now time for number 3, a good implant versus a good implant system. Actually, I can see many good implants in the market, and I can see many good implants on x-rays with 20 years follow-up and 15 years follow-up that has minimal bone loss, but unfortunately success is not just only survival. We have many factors to think about. So thinking about the implant as a successful implant system is totally different than thinking about it's just surviving in the patient's mouth or it just failed. So we don't think about failure anymore, but we think about success. How the implant is going to integrate is how good is the implant, porosity, the scaffolding, the acceptance of the bone cells to the implant surface, porosity, and the microtexture on the implant surface provides a good implant surface for osseointegration. And this initiates the whole reaction of cytokines and downgrading the inflammation and all the cascade that we go through during osseointegration, especially in the early stages. And this supports a good bone to implant contact. And actually, when a company invests on improving its bone to implant contact, it produces a good implant. Then time comes when they invest in more prosthetic components and more kits and more softwares to improve themselves and as an implant system, not just only a good implant. So bone to implant contact is well known to be 50 to 60% of the whole volume around the implant formed of pure bone, and the other 40% is bone marrow cells, fat cells, blood vessels, and sometimes fibrous tissue at some points. So a unique technology introduced by Osstem is the super osseointegration, the SOI, to increase the wettability of the surface of the implant, to increase the contact between the cells and the surface of the implant. This picture is from the Osstem R&D, showing the attachment of the bone cells and the multi-nucleated giant cells on the surface of the implant due to high hydrophilicity. And actually, this is a combination between many techniques, using micro roughness techniques to increase the roughness of the surface, and acid buffer techniques. It's like a liquid that the implant stays inside to improve the wettability of the surface of the implant, and when placed in the patient's bone, aids in how much cells are going to attach on the implant surface. So we have the SOI now, the super osseointegration surface, that is maybe faster in osseointegration than the regular the regular surface of the TS3. But actually, the implant design and the implant surface didn't affect the middle facial recession in the modern literature like it used to be in the old days. The old days, we thought about osseointegration more and more than crestal bone stability. So what we thought in the past days, more hydrophilic the implant. I can load this implant with immediate loading. I can place a crown after only 1 month, maybe 6 weeks. Nowadays, we don't think this way. It's of course it's going to improve the bone to implant contact, but many factors emerge in the literature, as you see, that affects the crestal soft tissue. For example, the thickness of the tissue, the supracrestal height of the tissue, and the bone thickness around the implant, not only the implant design. So the evidence is supported by many tips and tricks in the workflow, not only in the manufacturing of the implant, like providing digital solutions for the implant that you're providing. Providing a good implant is not enough. You should provide a good kit. You should provide a good digital library that supports this implant, prosthetic components of variable sizes and lengths and types of superstructure to support this good implant. So a good system should support many things, such as digital workflow, armamentarium, kits and sizes of implants, and finally a stable connection, the implant abutment connection that supports the supracrestal fibers and prevents crestal bone loss with the years. We have a direct, very easy to memorize and very easy to calibrate sizes in the Osstem system, from 3.5, 4, 4.5, 5. Those are the most that we use in different areas of the mouth, and preferably it's placed 1 millimeters of crestal because it has an internal connection and an 11-degree sturdy, very strong, and I see very stable with the years. I have long-term follow-ups after 7 and 8 years with stable connection, stable crestal bone loss, and a strong internal hex connection that supports the crestal bone around the implant. All this, it's not only the surface of the implant that matters, but also the internal connection, and also how many options that can you offer in the implant design to aid in this. Not only the implant surface, we have the aggressive type, the TS4, and the regular type TS3, in the systems. Those are the two more common implants that's used in the Osstem system, and also many kits, more than 12 to 13 kits that supports this workflow. A good implant is not necessarily a good system, but a good system is definitely having a good implant. So this is my message that I want to deliver by this section. And now we go to the last section of our presentation, the OneGuide Kit. Now with the last section of our presentation, the OneGuide Kit, I'm going to take you through the components of these kit and how to make the maximum benefit from the use of each and every component. I've been a big fan actually for the past 2 years using this magnificent combination of drills, fixation screws, implant drivers, and profilers, tissue punches. Everything you need, you're going to find in the OneGuide Kit, enhancing the predictability and smoothing the process of implant drilling and implant placement, especially in the aesthetic zone when you don't have much margin of error. Actually, all the guided kits on the market have nearly the same components, from the guided drills to the guided implant placement through the drivers. Yet, what you find different between each and every kit, most probably in the good high-end products, the quality of the manufacturer and the design of the drill in comparison to the design of the implant. When we are using tapered implants, we need somehow a similar anatomy in the drills to just mimic the preparation in the bone and achieve primary stability on all equal torque throughout the implant body. It's not like having the implant just stuck on the coronal third and free from the apical third. So the drill design follows the famous 1-to-2 taper kit from Osstem. This is also one of my favorites, including the standard side cut drill, stopper drills, and the taper drills. Actually, the side cut drill is something that I hope the Osstem R&D just add to the OneGuide Kit. It's a pretty useful tool, very sharp and sturdy, easy to use. I use it with every drilling protocol. Even if I'm working with the OneGuide Kit, I always start with this side cut. Then I go to the taper drills. The guided taper drills have a similar design to the 1-to-2 taper drills, with the stepping for getting the implant engaged in the apical third as much as possible, with super sharp tip, and the coronal flaring with the taper that minimizes the engagement of the implant threads in the cortical bone in the coronal third to minimize the crestal bone loss. And as I mentioned before, it's better to place the implant in a subcrestal position. All conical connection implants, better to place them maybe 1 to 2 millimeters subcrestally. So see the marking on these drills. For example, the blue one is the final drill for the 4.5 implant. The final line, black line, indicates the length of the implant. Then you have an extra 1 millimeter to the bigger flat stopper to just make things easier and place the implant 1 millimeter subcrestal without having to calculate this 1 millimeter in your drilling on the drill. So this is a close shot of my side cut drill. I've been using it for 3 years so far. It's still sharp and lusty, and I love how these products are manufactured. They're really efficient and really cost effective in exceeding even sometimes 50 to 100 osteotomies, and they stay as good, as sharp as they started 2-3 years ago. Let's take a look at the OneGuide Kit. First of all, the thing that we start with is the initial drill. We have a thinner one for soft bone and a bigger one for a little cortical bone, in order not to do under drilling in a horizontal direction and strain the cortical bone. Then we have the cortical drill for bigger implants like 4.5 and 5 millimeter implants, to just widen up the coronal third, not to strain the cortical bone. And let's also take into consideration the size of the implant. We have 2 sizes of the barrel in the OneGuide Kit. We have the 5 millimeter standard diameter of the barrel of the guided drill, and we have the 5.8 wide diameter of the 5 millimeter implant. When we do drilling for the 5 millimeter implant, we need a wider drill to accommodate the size of the drill, and also be in a bigger contact with the guide while doing this drilling protocol. The tip design, we also have a sharp tip design. It's not super sharp that can injure vital structure like nerves and sinus floors, but it's not a passive tip. You can just increase a little pressure and go 0.5 millimeter, sometimes 1 millimeter with the 3.5 final drill or the 4 millimeter final drill. And also the stepping, the design of the steps with the taper enables you to move laterally sometimes in the osteotomy to adjust the drilling position for the implant placement later on. They come in the regular lengths with Osstem 6, 7, 8.5, 10, 11.5, and 13 millimeter, with the extra 1 millimeter after the laser mark to enable you to place the implant subcrestally. Then come the implant driver with the 6 yellow marks on the neck of the driver that indicate the direction of the hex inside the implant. And we always use the hex orientation timing to adjust implants in full arch reconstructions for the angles of the multi-unit abutments to match together, minimizing discrepancies in the parallelity between the implants, and sometimes in the immediate loading single anterior implant cases like I'm going to show you today. Also for the provisional restoration to be seated passively without problems. We have 6 implant drivers, 3 for the motor handpiece driven and 3 for the torque wrench hand driven. And a nice thing to notice that always the hand torque drivers are slightly smaller than the handpiece drills and the handpiece drivers in order not to cause false friction with the guide and give you a false feeling of torque while the implant's not engaged in bone. So when you measure this, you're going to find it a 4.8 or 4.7 millimeter rather than a full 5 millimeter. 5 millimeter is the handpiece driven and 4.8 is the hand driven. See the small gap between the driver and the guide gives you a very small margin of discrepancy in the guide, in the drilling protocol, and makes you not feel a false torque on the walls of the guide from the inside. Also, the yellow mark, when it matches the mark that you have in the guide, that means the hex orientation is matching the provisional design of the restoration, and it's going to be seated passively without any problems. We do a 90 to 100 micron offset for our guides in the OneGuide Kit, and actually this is dependent upon your printer and the resin that you're using. Most of the time these work with many printers and most resins. I just like to fix it 90 to 100 microns in all the guides. The next item is the flattening drill, one of my favorite tools to use with the guided kit and also with freehand implant placement. It comes in 2 sizes, the 5 millimeter diameter and the 5.8 millimeter diameter. We use it to do the profiling before implant drilling, sometimes after drilling, to shape the concavity of the emergence profiles and make the tissue follow this profile to get this beautiful emergence profile without any grafts. This case I've done without any soft tissue or bone graft, just manipulation of the bone anatomy and placing healing abutment on the day of the surgery, placement of the crown with perfect tissue contour, as I just mentioned in the previous section. The restorative contour guides the healing of the soft tissue. Then you have this beautiful profile after 1 month of loading. The 2 items after this are the tissue punch and the screwdrivers. We have 2 1.2 millimeter torque drivers and 1 hand screwdriver and 4 tissue punches with different diameters. The condenser that I use also as a ruler, it's a ruler for measurement of the depth gauge. The black mark indicates 10 millimeter, and you have 11.5 and 13 millimeter marks after the 10. Also the torque wrench, one of the best latch mechanisms on the hand torque wrenches that never misses, and with very minimal problems on a very long time. I've been using mine for 4 years so far, and it's as good as new. Let's start with our cases. This is the protocol that we always use in the aesthetic zone. Take a scan, CBCT, superimpose both data over each other, and do the wax up. After doing the wax up, start placing the implant position in the cingulum of the tooth, of course, with the consideration not getting a very palatal position, not to overdo the buccal emergence angle more than 40 degrees. We only need 30 to 40 degrees of emergence angle to maintain a healthy soft tissue around the implant later on. We start the drilling protocol and preferably place the implant with a fully guided approach through the guide with a hand torque wrench to ensure that it's going inside in the same position as planned. This is a prefabricated temporary crown you see on the right pictures that I've done before the surgery and installed after implant placement with it's cemented extraorally with resin on the tie base or on the implant abutment, then screwed inside the patient's mouth to support the tissue. And one of the main big advantages of working fully guided with immediate temporization is maintenance of the soft tissue profile and not having to lose what you started with: soft tissue papilla position, the labial tissue thickness, and the emergence profile. Forever, when you have these combination preserved from the first day the patient coming into your office to the last day you deliver the final crown, you will not lose a single millimeter of this with correct management and placement of a temporary restoration on the same day. Sometimes I do irrigation channels in the guide. That's just a small hack to minimize heat generation and increase the irrigation that reaches my guided drills, as the OneGuide drills are very sharp and very efficient. They don't cause any lateral pressure on the guide while drilling, yet I have to do extra irrigation. Not all the time, it's not recommended, but I do it to minimize any errors because I love to work digitally. I love to work fully guided, but we always worry when we work guided from the heat generation below the guide. So it's preferably to make your precautions by extra irrigation in this part. This is the second temporary crown that we do 2 weeks after the surgery, sometimes only 1 week. Better contour, we take a scan in the surgery and we do this accordingly. We do this crown after 1 week. We install it in place. Then this is the beautiful healing of the tissue 4 weeks after the surgery, after dual zone grafting of the jumping gaff, of course, with an allograft material. Then we come back again after 2 months. Of course, we cannot avoid the crestal bone loss that happens after tooth extraction, but we can compensate this with adding more tissue from the palate, preferably a deep tissue, to just prevent much scar formation in this area. We tunnel a partial thickness tunnel, place the soft tissue graft, maintaining the papilla and the margins in the same place. On the same day of the connective tissue graft, we have to put back the crown in place and start to pull the tissues over the contour of the crown that has been designed in the software to guide the tissue healing in identical form and shape to the adjacent tooth. The central is done with a crest of contour that matches the contralateral central for the tissues to follow the same curve as the other central. So it heals beautifully after 2 weeks. Leave it for 2 more months of maturation for the tissue to be more pink and more healthy. Then start taking our final scans to do a final restoration. Same rules that go for the provisional restoration goes to the final restoration from contour, subcritical. The subgingival part has to be as concave and flat as possible with small convexity with 0.5 millimeter subgingival ceramic to just push the tissue in the ideal shape. Highly polished subgingival contour also enhances the attachment of the hemidesmosomes on the zirconia surface. This is how it looked like. Beautiful, patient satisfied from since day one she entered our office to the final delivery of the crown. Never 1 day without a crown. A similar case that an upper central incisor of a friend of mine that we extracted due to vertical root fracture. This time I just decided to place the connective tissue graft on the same day of the surgery to save time, and also the case was a thin high scallop bitype. I feared much recession after tooth extraction. This is the prefabricated temporary. It does the job. I don't like it so much, but it just does the job for the patient not to go home without any tooth. only 1 week, and we prepare a better one with a polished contour and a subcritical contour that's concave and healthy around the tissues to help in the healing of the tissues. We load it after maybe 5 days after the surgery, then it heals beautifully after 2 more months. The more we leave it, the more it matures, and we just sometimes do some fine touches with laser or with electrosurgery to fix some scars around the gingiva. It looks beautiful after 4 months of healing, and now it's time to go back and take the scan for the emergence profile. This is the untouched profile since day 1 when we did the surgery. Maintained by the provisional restoration. This is a declaration that we have planned the depth of the implant in a good position to the future zenith 5 millimeter to allow for the grafting procedure, to allow for the curvature of the crown to be gradual, not to be abrupt 90-degree angle, and to allow a healthy looking emergence profile that satisfies the patient and gives a natural look for the central incisor. This is a comparison between the before situation and the after situation. We just take 2 scans of the patient before and after, and we superimpose these scans from common points that we find on the model on other teeth than the one that we did the surgery. And we start superimposing the centrals and doing a cross section to measure discrepancy and the changes of the soft tissue. We wanted the soft tissue increase in length. Let's see what happened after the surgery. 4 months after the surgery, the tissue just went down 1.2 of a millimeter. And this gain just fixes what we started with. We started with a little bit of a recession, and we ended with 2 equal gingival margins on the 2 centrals. Similar case, single central incisor. We always like to work fully guided. Remove the tooth, place the implant, prepare the crown on the table before the patient enters the office. Then they place the implant fully guided. Sometimes I use the side cut drill, as you see in the upper left picture, to flare the palatal wall before putting in the guide and doing the drilling. We're just doing some flaring on the palatal wall, not to slip the guide inside. Then place the implant through the guide. Most importantly, the yellow mark with the mark that we do in the guide to aid in the hex orientation and make the crown goes down easy without any problems. Another scan in the surgery, and this is the profile after only 1 week from the surgery. This is the other provisional number 2, provisional restoration, polymethyl methacrylate, milled of course, and go back again and screw it in place to hold the tissue in place. Beautiful result, and the patient goes home satisfied that she has a tooth, not a single day without a tooth. The last thing in my presentation is the last part of the OneGuide Kit are the fixation screws. And of course, when we have teeth to fix the guide on, like the previous cases, we don't need extra fixation by screws. But sometimes, unfortunately, we need to extract the teeth and fix the guide in the bone to make a full arch reconstruction, for example. So here, the patient came to us with, I'm going to show you the plan, wanting to replace all the teeth and multiple endodontic failures, multiple extractions, and a detrimental dentition that needs to be replaced. We do the plan on the software, of course, as we start always taking a patient scan, taking a CBCT scan, superimposing both, and of course with the wax up. The white model is the wax up, the design of the future teeth that we need the shape to be this way. And we start placing our implants in the bone in reference to the positions of the final teeth. We shouldn't place the implants anyway. We, as much as possible, sticking to the teeth that to be centralized in the cingulum of the teeth to get a beautiful FP1 restoration. These implant angles are not parallel, as you see, but we can make the multi-unit abutments parallel by adjusting the angles of the hex orientations through the yellow marks, as we saw in the past 2 cases. This is the base guide that we place on the teeth, used for drilling of the holes for the OneGuide Kit screws to go inside. Then afterwards, we remove this and place the foundation guide, the yellow one. It's called the foundation guide. And the drilling guide, the blue one, comes over the foundation guide. And the provisional restoration also lands over the foundation guide. So the foundation guide is the common factor for everything, just like a puzzle, to get attached onto it, including the drilling guide and the provisional restoration after implant placement. We go to the printer and print all these. Go to the patient, start fixing the first guide and do the drilling, remove the teeth, place the foundation guide and fix it with the screws, start drilling through the guide, placing the implant through the guide. In these situations, the implant have multiple divergence angle and we don't need to work freehand and just get stuck up at the end of the surgery with non-parallel implants. So here they are having multiple divergence angles, yet we have parallel multi-unit abutments because we chose angled abutments and we did a good timing of the multi-units with the yellow marks on the drills. Now we have parallel multi-unit abutments. We go to the scanning protocol. This is a continuous scanning strategy provided by iConnect software, iConnect company. A nice technology that also is compatible with Osstem implants to be used in cases with maybe intraoperative scanning with a lot of blood. To stay away from the gingival margin, we take two scans: a scan for the tissue to see the papillae and the labial margin and the palatal margin and the position of the implants, and another scan with the extra long scan bodies to record the position of the implants. We then just go to the software and design another provisional number 2, also like the single centrals I just show you before. Then we go back again and mill this restoration and put it back in place, maybe only 1 week or 10 days after the surgery, to shape the tissues and lead the healing of the tissues post-operatively. So this is how it looks like after only 10 days from the surgery. Patient is very satisfied. He's going home with the teeth from day 1, the pickup that we did on the surgery, and the nicer one we did 1 week after the surgery. Sometimes if you have the ability to design and mill this restoration only 1 day, the patient can come in the morning, do the surgery, go home at the end of the day with the restoration, and the patient experiences will be really, really impressive, and this will cause you a very good patient satisfaction and follow-up. I always remind myself and remind you to work in a team as much as possible and work on selecting the best biomaterials, selecting the best patients and the best prosthetic options, in addition to training with guided workflows. Thank you so much for your attention, and I hope I'll be with you another time. This is Dr. Ahmed Ashraf. See you. Bye-bye.